So you order an ultrasound for some vague abdominal pain, and bam, the report comes back, gallstones noted. This happens all the time, right? It's one of the most common incidental findings out there. But the real question is, now what? Do you tell the patient not to worry? Do you call up a surgeon? Today, we're going to build the mental algorithm to answer that question step by step.
And let me tell you, these findings are everywhere. In the US alone, we're talking about 6% of men and up to 9% of women walking around with gallstones. And a lot of them have absolutely no idea. But that one little line on an imaging report, well, it kicks off a whole decision-making process for you. So, what's your first move?
This is it. This is the big question. Now what? Do we just reassure them and send them on their way? Or is this a one-way ticket to the operating room? Does the size of the stone matter? Let's build the framework so you know exactly what to do. Okay, here's our game plan. First, we'll get the lingo down so we're all on the same page. Then, we hit that first huge fork in the road. Is the patient having symptoms or not? We'll follow both paths. Then, we'll untangle that confusing puzzle of atypical symptoms. And finally, we'll boil it all down to the key principles you can take with you.
All right, first things first. Before we can even navigate this algorithm, we have to be super precise with our language. Let's nail down the key terms we're going to be throwing around.
The number one term you have got to master is biliary colic. And listen, this is not just any old stomach ache. It's a very specific, characteristic pain. You know the story. Right upper quadrant, maybe radiating to the back, often kicks in after a fatty meal. It's the gallbladder signaling that a stone is causing a temporary jam, but, and this is critical, without any signs of a full-blown infection or inflammation.
So, that biliary colic, that's the defining feature of what we call uncomplicated gallstone disease. This is really our focus today. The patient is definitely symptomatic, but the situation hasn't escalated into a total mess. And making this distinction is absolutely crucial because it separates a manageable, planned problem from a potential emergency.
And this is the other side of that coin. This is when things have escalated. When we talk about complicated disease, we mean these heavy hitters: cholecystitis, cholangitis, pancreatitis. These are the real emergencies that demand a totally different, much more urgent approach, and that's a topic for another day.
All right, with our terms defined, we can now walk into our patient's room. We've arrived at the very first, and you could argue the most important, branching point in this entire decision tree.
And here it is. Simple, right? But everything hinges on this. Is the patient actually having symptoms from these stones? We're talking that classic biliary colic. Or are these stones just silent passengers, completely innocent bystanders? The answer to this one question dictates everything that comes next.
So let's head down path A first, which, by the way, is going to be the most common scenario you'll encounter. This is the patient whose gallstones were found purely by chance. They feel totally fine. Welcome to the watch and wait approach.
For the vast majority of these patients, the best thing to do is, well, nothing. It sounds weird, but it's true. The annual risk of them actually developing symptoms is low, somewhere around 1 to 2%. That's often way less than the risks that come with surgery. So your main job here is actually patient education. You need to teach them what biliary colic feels like, so they know exactly when to call you if things change.
But, and this is where you earn your stripes as a clinician, most patients does not mean all patients. There are very specific, high-risk situations where leaving those stones in place is actually the riskier option. So when do we break the rule and intervene?
You really need to have this list memorized. The common thread for most of these is an increased risk of gallbladder cancer. A porcelain gallbladder, that's a calcified wall, or really large stones, like bigger than 3 centimeters, are thought to cause chronic inflammation, which is a setup for malignancy. Then you've got other high-risk folks, like patients with sickle cell who are just constantly forming pigment stones. Knowing these exceptions is just as important as knowing the general rule.
Okay, let's hop over to the other side of our algorithm, path B. This is the patient who is here because of their gallstones. They're presenting with that classic, miserable biliary colic.
When someone's in the middle of an acute attack, you've got 2 clear goals. Goal number 1, which is obviously the most important thing to the person in front of you, is to get their pain under control. Fast. Goal number 2, once the immediate crisis is over, is you have to make a plan for the long term so this doesn't keep happening.
So when it comes to pain control, the evidence pretty strongly points to NSAIDs like ketorolac as your first-line therapy. They're not only just as good as opioids for pain relief, but there's also some thought that they might actually reduce the inflammation and help prevent the whole thing from progressing to acute cholecystitis. Opioids are really reserved as your backup plan for when patients can't take NSAIDs or when they just aren't enough.
Now let's talk about a piece of classic medical dogma you've probably heard a million times. Don't use morphine for biliary colic. It causes sphincter of Oddi spasm. Well, while it's true that all opioids can increase that pressure a little bit, there's no solid evidence that morphine is any worse than the others or that this effect is even clinically significant. So that old teaching about having to use meperidine, you can pretty much let that one go.
Once that acute pain is under control, the conversation has to shift. Because just managing the pain doesn't fix the underlying mechanical problem, right? The stones are still there. That's why elective laparoscopic cholecystectomy is recommended. You got to remove the source of the problem to prevent future attacks and, more importantly, to stop a progression into those serious complications we talked about.
Now we're entering the gray area, the clinical detective story. What about the patient who you know has gallstones, but their symptoms are just fuzzy? Maybe it's some bloating, some nonspecific upper belly discomfort, or dyspepsia. This is a really common and genuinely challenging situation to be in.
Before you even think about blaming the gallstones, your number one job is to be a good detective. You have to conduct a thorough search for other culprits. Could this be GERD, peptic ulcer disease, gastritis? It's totally possible the gallstones are just an innocent bystander, and sending that patient for surgery would be a huge miss.
So, if your detective work comes up empty, here's a really practical approach you can take. You can try a 3-month course of a medication called ursodiol. Now, what's interesting is that it can sometimes relieve the symptoms even if it doesn't dissolve the stones. So, if their symptoms get better on the trial, that's a really strong clue that the stones were the problem, and that makes cholecystectomy a pretty reasonable option. If they don't improve, you pivot back and start treating for other things.
Okay, we've covered a ton of ground, moving through every branch of this decision tree. Let's pull it all together into one final high-yield summary that you can actually use. This table basically brings our entire algorithm together. Just look at the logic. If the patient's asymptomatic, the risk of surgery is usually higher than the benefit, so we wait, unless they have one of those specific high-risk features. If they have classic biliary colic, the risk of it happening again or getting worse is high, so the path leads to surgery with NSAIDs to bridge the pain. And for those fuzzy, atypical cases, our job is to investigate everything else first, before we even think about the gallbladder.
So let's end with this. Following the main pathways of this algorithm, that's the easy part. But real clinical excellence is found in the margins. It's in recognizing the outliers. The real challenge isn't just knowing the rules, it's mastering the exceptions. So as you see patients, ask yourself, which one with these incidental gallstones might be the one who quietly fits the criteria for prophylactic surgery? Thanks for joining this explainer.